Still seems to be doing the same thing, like the computer's freezing. Can you guys hear me?
Yes.
Yes.
Okay. I apologize for this. When I'm trying to share my screen with your guys' system, it's not letting me.
Okay, Dr. Layman,
I sent you the slides earlier.
I have your presentation. I can share my screen and you can tell me when to switch.
Yeah, why don't we do that? So I think now that my computer's frozen again with trying to share the screen with you guys, I'm going to have to log back on. I'll be right back. 1 second.
Okay. Technology is wonderful when it works. All right, Dr. Layman, you are muted.
Is that better?
That is much better.
All right.
All right.
Somehow it's freezing my keyboard, and I don't understand why, but okay, we'll just go ahead this way.
Would you like for me to bring it up and you tell me when to switch?
Yes, please. That's going to be the easiest thing because it's not working.
Okay.
Here.
You know, that's why we have a contingency plan. Just give me a second. Let me get it into full presentation. All right, Dr. Layman, whenever.
All right. Beth contacted me a few months ago. Actually, I was out of the country at the time, and she asked me if I'd be willing to talk with you guys at your meeting on the topic of trauma surgery. So I do appreciate you guys having me here this evening. I will, full disclosure, I take a lot of these Zoom meetings, WebEx meetings, but this will be the first time I've given a long form presentation at one of them. So please bear with me. So we can go ahead to the next slide. So I thought I'd start us off with an overview. So I'm going to touch on a few points tonight. One is kind of what trauma surgery is in general, and then what the trauma surgery program at Henrico Doctors Hospital entails, and finally some case presentations. This photograph is from, unfortunately, a year ago. They didn't have this kind of fanfare this year on my block, Hanover Avenue, but this kind of epitomizes trauma surgery. Somebody hanging off the back of a motorcycle, full force, trying not to or becoming a skeleton. So this is one of my favorite pictures that kind of epitomizes trauma surgery. So we can move along to the next slide. So trauma in general is one of the leading causes of death in the United States. It's a medical issue. It's not just an issue of trauma. In the age groups from 1 to 44, it's actually the #1 leading cause of death in those age groups. And if you look across all age groups, it's within the top 10. If you leave out the infants, the zeros through the ones, through 1 through the end of life, trauma is at least the third, trauma and injury are at least the third leading cause of death in those age groups. It was actually one of the first indications for any kind of surgery, in that people got hurt even back in caveman days when medicine was done by mixing various leaves and potions together. But it was one of the first indications that to actually do any kind of operation. Someone's hurt, we have to find a way to fix it. The military and wartime medicine has really advanced trauma surgery, and I'll speak on that a bit later on in the program. But the American College of Surgeons kind of formally recognized trauma surgery as a specialty of itself in the 1970s, sort of creating the American College of Surgeons Committee on Trauma, creating the ATLS protocols similar to ACLS, BLS, or PALS. And trauma has really kind of become its own standalone specialty in the last several decades. This photograph here is from an X-ray taken while I was deployed earlier this year, or last year actually, in Afghanistan. You can see there's a large projectile overlying the left side of the patient's lower abdomen or lower pelvis, and it was a 50 caliber round that a young 20-something-year-old soldier was struck with during his deployment in Afghanistan last year. You can move ahead. So what is trauma surgery at Henrico Doctors Hospital? So that's a photo of our hospital from the air there. So Henrico Doctors Hospital is a level 2 trauma center. We're American College of Surgeons verified trauma center. I'll talk about a little bit about what that means in a bit. But in addition to trauma, we have a large contingent of medical specialties there. We provide open heart surgery, vascular surgery, organ transplants, stroke care, critical care resources, and our trauma surgery program started. It's one of the newer programs in the city, but it started back in 2016. So as you guys probably know from being in the city, Henrico Doctors Hospital is part of the HCA hospital system. This is one of the national corporate slides for the trauma systems overview. You can see that there's a little map there that shows where the HCA has a footprint in the country and where in each community we have hospitals. As you can see, we have 64 trauma centers in our hospital system, which causes HCA as a contingent to be about the largest overall provider of trauma care to patients in the United States. So there's level 1, 2, and 3 types of trauma centers. The difference, is and what they provide. In the city here now, we have 2 level 1 trauma centers. That's Chippenham and VCU. We have our center, which is level 2, and level 3 is another type of trauma center. And they each have to, each of the state and the American College of Surgeons certifications sets the requirements of what each of those centers needs to provide. As you can see, as a whole, the HCA accounts for about 4% of all trauma centers in the United States and about 4% of all trauma admissions in the country. So the history of trauma at Henrico Doctors Hospital. Back in 2015, the administration set the groundwork for looking into the regional needs for additional trauma programs. Based upon the number of trauma admissions to the region's trauma hospitals every year. And the state felt that indeed there was enough business to go around, so they granted us the ability to look for state designation. Back in 2016, working with our administration and our doctors at Henrico Doctors Hospital, we were able to get a preliminary trauma designation from the state. A year later, they came back to review us and gave us a full trauma designation. Over the course of the year in 2018, we sought the preliminary and full designation from the American College of Surgeons, and they were recertified with the state back in 2019. Trauma, like several systems, several other medical care systems, is something that's very highly regulated. They don't want anyone just showing up and saying, hey, we're a trauma center. Both the state and the American College of Surgeons have a thorough evaluation scheme to decide who's an acceptable trauma center. And I'm happy to say, as one of the doctors and the medical director for the trauma program that started our program, that we've not had any, on any of the evaluations, we've not had any deficiencies by either the state or the American College of Surgeons. So what is a trauma program? What makes it up? We can say, hey, we're a trauma center all day, but why is one hospital considered a trauma center compared to another hospital? Next slide, please. So this is a little cartoon that I like that sort of shows, there's a lot of words on there, but if you follow the cartoon from the bottom, what happens with our trauma center, we start at the outset from the pre-hospital care, because any trauma system, it's great to have a trauma hospital, but our goal is to have in Richmond area a trauma system, which is a number of trauma hospitals working together in consort with the pre-hospital care and the after-hospital care to provide the needs of the patients in the community. But so it starts pre-hospital. It starts with the EMS. It starts with the frontline providers, bringing them into the trauma center, in the operating room sometimes, or the intensive care unit, working to get out of the intensive care unit eventually onto the general surgical trauma ward, and then into the rehabilitation center, and then off to home, so where people can sort of recover from their injury and enjoy a good quality of life after being injured. Next slide, please. So our trauma program at Henrico Doctors Hospital is a surgeon-led program. So we have 7 surgeons on our trauma panel. 3 of them, myself included, are military combat trained surgeons. We have 1 person who's went ahead and gone on to get a critical care surgery fellowship. Interestingly enough, there is no fellowship in trauma surgery. You hear fellowships in cardiac surgery, vascular surgery, and then people talk about trauma surgery, but there's no formal trauma surgery fellowship. The American College of Surgeons recognizes the critical care surgery fellowship, and that's what a large majority of trauma surgeons, especially at level 1 centers, because they also have to cover the ICU at the same time, will be fellowship trained in. And then 4 of our surgeons also trained at the VCU's level 1 trauma center during their training career. So of those surgeons, there's always someone on site, 24/7, 365, and we're responsible for the trauma admissions and any other kind of emergency injuries or acute care surgery that might show up in the hospital. It's not just myself and my guys and ladies that work under me. We also have to have our subspecialists, and you can see here orthopedic surgery, neurosurgery, plastic surgery. They have a variety of specialties. With the orthopedic surgery, we have our general orthopedists along with our complex pelvic care surgery and hand surgeons. And then on the other side of the slide, you can see the other medical specialists. Now, we had all of these all along in our hospital, but if you ask people, the members of the medical staff, I think some people are online today with us, that the development of the trauma program has led to the improvement for the hospital in each and every one of these categories. Now we have radiologists on site. Now we have interventional radiologists available to the hospital 24/7. Our emergency department is better staffed than it was, and our response to not just trauma care, but to any care for patients that show up at our hospital has been plussed up because of the development of our program. But as you can imagine, you guys being critical care nurses, trauma is more than just what the doctors do. And we've come to our trauma program with a very holistic approach as well, very multidisciplinary centered approach. So it starts in a pre-hospital setting with EMS providers and community providers. We, unfortunately, before the current times, when we could have in-person conferences and meetings, we would regularly staff EMS Saturdays or EMS evenings, where we would serve dinner and provide lectures. And even, some of my favorite EMS lectures were the ones that we worked together with the various units, where we would talk about a case and they would present their side of things, and we would go on to talk about our side of things. And each group of people would learn, what's going on in each section. We also have a large amount of community engagement. It is a requirement of all trauma programs to engage the community, and we do teach some community medical care issues. Now, of course, in the days of COVID, this has been curtailed, but it was there beforehand, and hopefully it's going to get there again. As far as the medical staff, you can't take care of trauma patients without a huge component of the ancillary care staff. So you've got the doctors, which I mentioned before, but then we also have the nurses and the other ancillary staff. If you look at the diagram, this is how we set up our trauma room. So we have 2 trauma rooms at our hospital, and the expected participation is listed here. Now we have different trauma levels for depending upon the injuries. Not all of these people are expected to be there for every injury type, but I think the die has been cast over the last decade or so. I mean, I remember treating trauma patients back, 15 or 20 years ago. You dealt with them in the emergency room, and then they went up to a different level of care. And at each step, a whole new set of providers were going to be working with them. In the more multidisciplinary approach, you can see on the slide that we have SICU nurses or critical care nurses down in the emergency room in the trauma bay, starting the initial resuscitation of the patient. And this is what we do with our high-level traumas, especially with all the high-level traumas, but based upon our criteria, those are the ones that are expected to end up in the intensive care unit anyway. So it's, I think, a great partnership to have the critical care nurse down with the emergency room nurse so they can provide that immediate care. I know in the past, for sure in our hospital, and I know in other hospitals I've worked at, there's been a little bit of a dichotomy between critical care nursing staff and the ER nursing staff. Everyone's got their gripes, but I think, in trying to bring the two groups together, at least with trauma, we've been able to try to improve the relationship between those two specialties. And also you can see our ancillary staff, they get involved early on. We got respiratory therapy and lab down in the trauma bay, physical therapy and occupational therapy. They're not really needed at that time, but we get them involved early on. And all these groups are also involved in the multidisciplinary rounds, which we hold daily with our trauma surgery rounds. And case management is a huge plus up for us. In the initial phase of our trauma rollout, we didn't have a dedicated case manager. It was one of the more important points that I stressed with our administration, that our program needed its own case manager to try to really improve the throughput of our patients and trying to get them into quality places, be them rehab institutes or skilled nursing facilities, so that we have the space and ability to take care of new patients. I like the fact that this year also we have a more direct rehab involvement. As some of you guys know that work at the HCA hospital systems or work at other hospital systems, HCA as a whole has more rehab beds in Central Virginia than any other hospital between us and Johnson & Willis. So it's nice to have the ability to have one of the accepting staff from that facility round with us on a daily basis, because I know those beds are competed with by not just our trauma program, but the trauma programs at VCU and at UVA, and by a lot of other specialists that are looking for quality rehab beds for their patients. And finally, you can see the follow-up. I mean, we do staff a trauma follow-up clinic for our patients. Now they'll follow up with their neurosurgeons and their orthopedic surgeons as well. But just like we do to kind of bring it all together when patients are in the hospital, we want to make sure they're not lost to the winds once they get out of the hospital as well. Next slide, please. So now some of the slides get a little more exciting, but we do offer a lot of educational opportunities. So there's the ability for our staff, our medical staff, our nursing staff, and our ancillary staff to get CME opportunities. We've got some, there's always national meetings, some of which I'm required to attend. There's regional meetings. I try to work with the people down at VCU or the people down at the beach to try to work in with their regional meetings as well. And Virginia, the Virginia chapter of American College of Surgeons does have a committee, its own committee on trauma, which we're actively participate with. Local is in the city. Chippenham hosts CME weekends. Again, this has kind of been the before times, as does VCU. And then we have some in-house CME opportunities available. We do run a trauma peer review meeting, which is CME eligible. All of our trauma surgeons are ATLS certified. That's the American College of Surgeons program in Advanced Trauma Life Support. That's a requirement in order to be on the trauma panel. Our nurses are involved with the TNCC, the ones that are involved with trauma. So that's going to be ER nurses, surgical ICU, surgical step-down nurses, and our trauma ward nurses. And then, as I mentioned before, we have EMS outreach programs, which we're fairly robust when we were able to have meetings. Hopefully that there's going to come back soon. Going along with that is our community outreach programs. And we have various injury preventions programs, one of which we were able to, we won an award from the state assembly on our matter of balance community outreach for falls. And then the American College of Surgeons supports a program called Stop the Bleed, which a lot of you probably heard of, but it's to train the very first line responders, kind of N-1, and that's kind of you and your friends next to you, how to treat emergency injuries until the EMS type first responders can arrive. Interesting photo here. I always like to tell stories, just like any doctor does, of fun cases, interesting cases. But this is an unfortunate lady who was involved in an assault, and she had multiple stab wounds kind of all over her body. We can see several stab wounds here on the neck. She also has a bunch of defensive wounds on her hands and arms. So this was an emergency case from last fall that I was involved with. A lot of blood loss, and kind of an interesting case with emergency exploration to stop the bleeding from an artery in the neck, while the orthopedic hand surgeon was involved with trying to investigate and repair all the injuries to the arms. Next slide, please. We're also heavily involved in regional collaboration. As you guys know, VCU has been a trauma powerhouse for many, many years. Chippenham, since I arrived here in the city 11 years ago, has gone from a level 3 to a level 2 and now to a level 1. We opened up as a level 2 center, and then we've got Southside Regional as level 3 and Mary Washington as a level 2. After we opened up, there was a lot of impetus to try to consolidate knowledge from all these trauma centers. And we have regular meetings with the newly formed Central Virginia Regional Trauma Committee. All the meetings were held at VCU. Now they're all held on this same Zoom platform. And it's not just on trauma, it's emergency preparedness, it's getting the doctors to know each other so that we collaborate rather than compete. I have a good relationship with a lot of the physicians and staff from all these hospitals. And then actually while I was away last year, our meetings kind of ramped up even more because of the coronavirus pandemic, because trauma surgeons are among the very people that are important in the fight against, broad-standing pandemics, because we involved with critical care, we are involved with the care of emergency patients, and unfortunately sometimes involved with triaging patients. Not every patient is going to survive, so we have to sometimes work to say, what's the best use of all our resources? You can see what our goals are there: increase the collaboration and improve the collaboration between the trauma centers and non-trauma centers. And we have reviewed some good cases as well. I like the fact that the trauma medical directors sort of have an open door relationship with each other. I was on the phone at the end of last week with Mike Abatanos from VCU, and we were just discussing citywide plans for what's coming up this week. And we've been working on that at our hospital, and I know Mike's been working on it downtown for several days now, just in preparing for the potential of a bad experience with the demonstration in the Capitol yesterday, which didn't turn out to be anything of too much problem, but even tomorrow. Because I'm sure you all are aware, of the big things that have happened in the last several years: the El Paso shooting, the Las Vegas shooting. If you really drill down on those incidents, the care of those patients was given by a trauma system, not just by one hospital. I always find it kind of uplifting when I hear about those programs. So the people from the Las Vegas shooting, the 3 hospitals involved, the University Hospital, the level 2, and the level 3, have given many talks over the last couple of years together. So all 3 medical directors give a large talk, and I've actually been able to see it twice at different national meetings. Interestingly enough, the level 2 center, which is an HCA hospital, actually took in more patients than the level 1 center did, mainly because no one actually knew what was happening that night. And at one point, the level 1 center shut down. They said they shut down kind of in error, but it still shut down to EMS traffic, so everything was diverted away from it. So they've got a lot of lessons learned, as does the El Paso shooting community. And I know the medical directors at several of the programs from different national meetings. And I think citywide, the development of citywide trauma systems is the much what we do and what we do well. We always check back on ourselves. So our trauma system, we've got many layers of review. We've got a multidisciplinary trauma conference, which involves the players from all areas of trauma. That's the doctors, the nurses, the ancillary staff, trying to see what's best practices, trying to go from case to case, what's going to be the best thing for us and for the patients. And you learn from each case, you develop things from each case, and you work towards improving yourself for the next case. We have our hospital CME allowed program, and that's our trauma PI/peer review. It's not open to everyone. It's open to patients medical providers that are involved with the trauma system, because there is some peer-reviewed sort of protected comments that go on in there, but it is a CME course that we run for the hospital. And then the trauma system then reports up to all these other committees: the Hospital Quality Review Committee, the Professional Practice Executive Committee, Medical Executive Committee, and Hospital Leadership Committee. And that's because we don't want to be working as a closed shop. We want to do stuff, and we want to be able to, show what we do and show what we do well. As I had mentioned earlier, that the majority of people that are at our site will say that the implementation of the trauma system has elevated the care and camaraderie and ability for the entire hospital. Here's another sort of kind of slightly grotesque, but always fun pictures to look at of another injury patient that was hit in the head with some sharp objects, and he had an intracranial injury, but he had this kind of very obvious external injury which had to be controlled rather quickly, but always something that shows up in the middle of the night. And I'm just noticing it now, all these slides are from different Octobers, so October must be kind of a bad time for riding motorcycles with skeletons or getting hurt. But another fun picture to take a look at. So this is sort of a snapshot of the data and the patients that we've taken care of over the years. The majority of what happens when you cross platforms, as you can see, not everything shows up. But so these are the injury types. Our 2 main injuries, which you don't see, are falls and motor vehicle crashes. So I think it says animal, blunt assault trauma, burn trauma. Can't remember what that other 1% was. Electrocution, it wasn't 0, but it's very few cases, so it rounds out to less than 1. Industrial, penetrating, and then the 2 large bars there. First is falls, and the next is motor vehicle crashes. That's what we mainly get. We get penetrating trauma sporadically. In looking at a trauma system, the goals of the level 2s and level 3s are to really offload a lot of the lower level trauma, so that the level 1s can focus all their energy on the super high level trauma, and that's our goal as well. We don't want to steal cases from other hospitals, but what we want to do is provide the best care for our people in our community. Next slide, please. So these next few slides just kind of list out the different procedures which we perform. And some of the slides, have some numbers by them, and that's just based upon our data. These are all the surgeries that we've done kind of since starting. So we can see what our neurosurgeons do. A lot of cranial work, a lot of spinal work, a lot of spinal injuries coming up. Next slide, please. So our orthopedists, they're probably the busiest single specialty in our surgery panel. As you can see, yes, another October. So this October slide was a motorcycle crash, and this patient had multiple fractures, not just to this femur, which you see there, which is broken in multiple places, but he had lower leg fractures as well, along with some other injuries. Next slide. We do a lot of thoracic procedures. We have our cardiac and thoracic teams, but several of the trauma surgeons also participate in thoracic trauma as well. We were among the first trauma centers in the region to do what's called rib fixation or rib plating. As Beth had mentioned earlier, before I showed up here in Richmond, I was involved in some academic publications on rib fracture plating. It's gone through its ups and downs as what is accepted as an accepted modality to fixing rib fractures. People used to do a lot of taping of rib fractures, then went back to treating them just conservatively. The long-term results were bad. So when I was doing my original research on rib fracture plating, we were using things that weren't designed for rib fractures. We were using fascial plates, we were using long bone plates to try to stabilize the ribs. And nowadays, rib fracture plating, which is another surgery that I take part in, is, I wouldn't say an easy surgery, but it's much less onerous than it used to be, because we have instruments and plates that are specifically designed for rib fractures. And in the case reviews, we'll discuss a little bit of that as well. Next slide, please. So the bread and butter of our trauma surgery panel goes along with abdominal surgeries and some vascular surgery, because the trauma surgeons on a surgical panel start off as general surgeons. That's where we all start off from. So a lot of intra-abdominal surgery. Several of it, we have other vascular surgeons available if the trauma surgeon that day is not well versed in vascular surgery, but several of us on the panel are well versed in vascular surgery and vascular repairs. Next slide, please. Another interesting case. So finally, we're out of October, but it's from last year as well. This, sometimes looking at surgical anatomy is a little difficult for people, but this is someone who was stabbed in the neck who came on one night when I was on. Working up neck injury wounds is always difficult because there's so much high value targets inside the neck. And a lot of times the wounds are very small externally. But one of the sure signs there's something wrong is when someone is talking with you or they cough and the sound or the bubbles come out of their neck, there's a definite problem going on. But for this patient, just as all neck wounds, mandatory exploration is required. If it doesn't penetrate the sort of muscle layer outside the neck, you can stop. But if it penetrates that layer, you have to keep going. And what you see here is a tracheal injury, which was repaired. Then you also have to make sure you're looking at the great vessels in the neck, the jugular, the carotids, and the esophagus laying behind the trachea. You could go and cut through the entire trachea to make sure the esophagus isn't injured, but that's not too wise of a thing to do. But so when you're working up neck injuries, penetrating neck trauma, there's a multi-faceted approach using radiology, using endoscopy and surgical exploration combined to ensure that there's no other injuries. Next slide, please. This slide represents our facial trauma panel. This is one of the hallmarks, I think, of our program. We have a well-versed facial trauma panel made up of plastic surgeons, otolaryngologists, and of OMFS or dental surgeons. because not everybody's going to be the best expert at repairing each type of facial fracture. So I like having the multidisciplinary approach where we have a variety of specialists on the panel. Now, in any one night, you're going to have one of them available, but a lot of these fractures aren't the most pressing injury for our patients. So if we need to get someone from the ear, nose, and throat guy who would have been great at repairing some complex, deep facial fractures, and it'd be better for them to be working with a plastic surgeon, we can rotate the patient load that way. Or if there's dental issues, we can get them to our OMFS colleagues that are on our panel. Next slide, please. All right, so here's the more interesting parts of the slide, case presentation, or our case reviews. So this is the first case that I'll talk about. So the background's 28-year-old female. She was an alpha trauma alert, which is our highest level alert. So she was in a motor vehicle crash versus a pole. She was traveling at about 45 miles an hour. Actually, who knows how fast people are driving? Because I know if the speed limit says 45 miles an hour, I'm not necessarily going 45. But when it gets reported by the pre-hospital providers, they tell us how fast the road is marked at, and we assume that people are going at least that fast. She was unrestrained. She had been drinking, and when she showed up at our hospital in the wee hours in the morning, she was combative. So we got the official alert, just after 2:30, and she got there a little before 3, and those are initial vital signs. So Dr. Cliff Deal, who's one of our trauma surgeons, he's also a combat veteran and trained down at VCU. He was the guy in the box, the guy on call that night. On the initial vital signs you heard from the EMS, but these were her vitals on arrival. So we can see automatically, young person with some hypotension, but some tachycardia, there's a problem. Her GCS, or the Glasgow Coma score, was low. The Glasgow Coma score is a score that goes from 3 up to 15. So 7's kind of right in the middle. But once people start getting into that 12 to 13 range, we know there's some, intracranial issues. Sometimes it's intoxication, sometimes it's injury. A lot of times you don't know, and you have to kind of figure it out clinically. But she was urgently intubated, started transfusion of blood cells, and what was done on her was called a FAST exam. So that's what's called a focused abdominal sonography for trauma. Essentially, it's an abdominal ultrasound done in the emergency room by the ER physician or the surgeon, looking for fluid in the belly. Some people have, if people have ascites, people on peritoneal dialysis, they're always going to have some fluid in the belly. If they don't, essentially humans don't have all that much free fluid. And if you guys are familiar with ultrasound, here's a picture of a FAST exam next in the slide next to you. On the top, there's a liver. On the bottom, there's a kidney. And then there's a black wedge off to the right side. That black wedge represents fluid in between the liver and the kidney, because in a right upper quadrant ultrasound, that liver should be sitting right on top of that kidney with really no interface in between, sort of like you see on the 7 o'clock or so side of the screen. So she had a positive FAST exam, which means she has fluid in her abdomen. So 28 years old with no history of liver failure, no history of dialysis. We know she's got fluid in there for some reason. And that fluid comes in the form of blood or of visceral contents. So she quickly got a Foley catheter and a central line and went off to the CT scanner. What we initially noted was bilateral rib fractures. You can see from this 3-dimensional, reconstruction of her chest wall that there's several rib fractures going down there on the right side. These 3-dimensional reconstructions are kind of neat. In real time, you can kind of spin them around. I think this was the best confirmation. It showed the most interesting fracture pattern. You can see that some of these fractures are lined up, and some of them are overriding or very far separate. So that's the difference between a displaced fracture and a non-displaced fracture. I think Beth pointing to one of the displaced ones. If you go just underneath that, Beth, you can see the sort of non-displaced where there's just an irregularity in the bony cortex. She had bilateral hemopneumothoraces. So, we've heard of pneumothorax. You probably heard of hemothorax. But when you got both, when you got a lung collapse and blood in the lungs, you get a hemopneumothorax. The hemoperitoneum, the lacerations to the organs, and some vertebral fractures. There's another couple of images in the next few slides. So this is another axial cut of the slides. You can see that this is the chest. As we're all familiar with X-rays, we know that X-rays are just a standard chest X-ray, but the machine takes thousands of these X-rays and creates this three-dimensional image in the computer. So if air is black, bone or metal is white, and everything else is kind of a shade of gray in between. So you can see on that right side, of course, there's a large amount of full black in there, and that's air outside the lung. And you can see the lung kind of in the center that's got some collapse, because that lung should be filling up that whole cavity. On the left side, the pneumothorax isn't quite as large, but you can see a little bit of it in front of the heart. And then posterior, because fluid is dependent, you can see some fluid building up in the lungs, but then behind the actual lung, you can see a lot of gray, especially on the right side, because that's where the higher injury pattern is. That there's the light gray, and then that little bit darker gray right underneath it, Beth, that you can point out, that's blood inside the chest. And you can see, I think, maybe one or two rib fractures on that picture as well. Down in the belly, just as we saw on the ultrasound, on the right side, you can see that there's a kidney. There's a spine bone in the back, which is that big white thing. And if you sort of travel off, towards the 9 o'clock from that, you can see kind of a round light gray kidney. Yep, right there. And then right above that, between the liver, which should be right adjacent to it, there's a little kind of a darker gray spot. And that's blood. Kind of corresponds to that same picture we saw on the ultrasound, where there's blood build up between the liver and the kidney. Next slide, please. And another couple of images here of this patient. So you can see that the liver should be a little more homogeneous than it is. You can see kind of a light gray on the right side, a light gray on the left side, and then this dark gray mass in the middle. And that dark gray is injury to the liver. So there's internal hemorrhage in the liver. And this is the coronal cuts. Again, some fluid underneath the liver here. You don't really see the kidney in this view, just because it's out of sync with this particular cut of the image. But looking at the axial image next to it, again, you can see right through the middle of the liver, there's a large injury. And the kidney shows up there again. Again, it's a little bit different cut than we saw in the previous image. So the blood is going to pool in a little bit different area. But when you see a liver like that, there's a big problem. Next slide, please. So our initial management for this patient, bilateral chest tubes to re-expand the lungs, to evacuate that fluid, ongoing resuscitation, and then direct admission, from the CAT scanner up to the intensive care unit. So looking at these cartoons here, they talk about blunt solid organ injuries, because we're academically oriented people, so we always want to grade things, right? Everybody wants an A, B, or C. Well, injuries are no different. So when you're grading solid organ injuries, they go from a grade 1 to a grade 5. Here's all the various criteria, but you can see grade 1 is a small injury, all the way up to grade 5, which is a huge injury. This person's injury, you can remember back from 2 slides ago, where it kind of cut through the middle of the liver. It was probably, it could be averaged a 4+ to a 5. Can you go back on those slides, Beth? Maybe up to the top versus previous. Yeah, oh, perfect. One more. So what we're looking at here, sometimes in injuries like this, you're going to go directly to the operating room. What didn't occur in this patient, which we don't see, so I can't show you. If you see the spine there in the middle, right above the spine is the aorta. It shows up so bright on that axial cut on the other X-ray because there's contrast in there. So there's IV blood contrast. So if we were to notice a large amount of that bright blood inside that liver, we would have known that there was ongoing internal bleeding inside that liver, and that would have prompted a little more of an operative involvement. You know, a lot of liver trauma, a lot of blunt organ injury trauma can be managed non-operatively. It's actually better for patients because you stabilize them, you resuscitate them, and the organs kind of heal themselves. So that's one of the other subtle signs that we're looking for, is that kind of bright blood flash inside the liver. Should I go on? Yep. And so, you know, I'd say this would be graded at a 4+ to a 5. Usually grade 5s are having some sort of intervention, either the operating room or interventional radiology. As we can see on the other side of the page, the kidneys, you know, any solid organs, kidneys, spleens, livers, they all have similar injury grading systems, where grade 1 is a small injury all the way up to a grade 5, which is essentially the organ's been torn off of its pedicles. Next slide, please. In any trauma patient, this is one of the hallmarks of ATLS. You know, they need to get a tertiary survey. So tertiary means the third. So you can see, where do the first 2 surveys come up? They come up when people are actually in the trauma room. You know, we're looking at initially at a primary survey, you know, looking at the ABCs, which are rearranged into the CAB, but, you know, ongoing circulatory problems, meaning uncontrolled bleeding, and then airway, and then breathing is a primary survey. And then the secondary survey kind of looks for the very obvious injuries down in the trauma bay. But especially if there's a lot of stuff going on, a lot of, you know, big, as we saw earlier, big scalp lacerations or neck lacerations or bleeding all over the place, it's kind of hard to find every little injury at that point. And some of these injuries are inconsequential in the immediate time frame. You know, they can be, but they do need to be found. So usually the next day, after the dust's a little bit settled, we sort of go in, evaluate the patients in what's called a tertiary survey. And so in this patient, who was kind of at death's door when she showed up at 3 o'clock in the morning, you know, the next morning, as the dust is settling, you know, we find a lot of other injuries. You know, they found a radius fracture, not so much because it was deformed, but because the patient had pain there when you're moving it around. But when she was essentially unconscious the night before, it's hard to find out where there's little amounts of pain. But you kind of, you know, look at, poke, prod, and look at everything that next day to try to evaluate this. So a radius fracture and a calcaneal fracture, which is a heel, lacerations in the lip, and tooth injuries, which needed to be addressed. She did have some ongoing issues with her blood pressure. So that next step for her is what's shown here in this interventional radiology X-ray. They essentially, you know, similar to a cardiac catheterization, they did a liver catheterization to see if there was, if her persistent low blood pressure and hypotension, or low blood pressure and tachycardia, was due to ongoing bleeding in the liver. And with this catheterization of the liver, we were able to show that there was no, you know, extra bleeding going on. Next slide, please. So this patient unfortunately had, you know, a fairly long ICU course, and, you know, with the help of our, you know, ICU nursing staff, you know, we found that she was having continued tachycardia, continued fevers. She eventually did get taken to the operating room, and after the first few days of her admission, to see what was going on. So she had an exploration. She did have a lot of blood in her belly, which was evacuated, diaphragm injuries, which needed to be repaired, the liver and the spleen injuries, which were found. Nothing that needed to be removed, but sort of, you know, there was some cauterization, there was some packing, but there was nothing that was, again, causing an immediate threat to life. But with a patient that's not doing well, sometimes we just have to sort of go in and kind of see what we find. Next slide, please. Additional ICU management, as you guys know, is dealing with the pulmonary system. It's one of the hallmarks of ICU care is respiratory support. She eventually did get a tracheostomy. We try to get those done within the first week if it looks like someone's going to be on the ventilator for quite a long time. She had a VATS procedure, which is a video-assisted thoracic surgery. It's sort of like laparoscopic or arthroscopic surgery for the chest, in that they were able to suck out any blood clots that didn't get extruded by the chest tubes. And she also had a repair. This was all done together, repair that diaphragm injury. And then she did undergo some rib plating. Was one of the indications for rib plating are multiple rib fractures, flail segment rib fractures, or fractures that are preventing people from being able to wean off the ventilator. So she is a patient who got one of those rib platings. Next slide, please. So she, again, this young lady ultimately did recover. She recovered well. She went from our step-down unit to our trauma ward, working with physical therapy and occupational therapy. Was able to get her tracheostomy decannulated, and eventually went off to rehab. I think we have some pictures next of some follow-up images. So if you can remember, this is the same patient. This is months later. If you remember those pictures from the beginning, the lung contusion, the fluid in the lungs, the collapsed lungs, the displaced rib fractures, and then that liver, which had essentially had that large central injury, kind of right through the middle of the liver. This is what time does. That's what time in a young body does. It allows these things to sort of heal up. In the picture, you can see of the chest, where you can see the ribs. On the right side, you can see some shiny objects hanging off the ribs. What those are actually the metallic plates that we put on the ribs after we sort of pick them up and piece them back together. And then these plates are held in by multiple screws, just like any fracture is repaired, to sort of keep the ribs in line so that they move more as a unit like they are supposed to do naturally, rather than moving in individual slices. Next slide, please. So this is another more interesting case sometimes. So this is another one of my personal cases. That's a photograph of me. I think that was taken back in 2015. No, yeah, that was a 2015 photograph from one of my other trips to Afghanistan. So I've been in the Army now. This is my 20th year in the Army as a surgeon. I've been involved in all varieties of Army medicine. I would say the most rewarding for me are probably the last few years, probably the last 5 years, because I've been involved with the Army Special Forces. So I'm one of the surgeons that gets deployed with the Army Special Forces. We get a little bit better equipment, we get a little bit more interesting missions, and which is always fun. And then we don't have to shave, and we can kind of dress how we want. So this mission was a joint mission between the U.S. Army Special Forces and the Afghan Commando Special Forces. Well, I'll talk to you about the story here next. Next slide, please. So in military and medical treatment plans, just like we have here in the U.S., level 1, 2, 3, 4 centers. Military has the same kind of nomenclature, but as the Army's if any of you have been in the Army, they always gonna do something a little bit different. So they kind of leveled up backwards. So first responders are called level 1, as opposed to the definitive care at a level 1 trauma center. In the military, level 1 is what is your buddy next to you, or you carrying your own first aid kit. And then it moves on to level 2, which is sort of very early on for resuscitative care, which is you don't have a surgeon. You might have a medic there, but it's not your individual artillery soldier patching up another artillery soldier. They do have some medical training. Going on to level 3 care, which is your first line of surgical care, and that's usually at what's called a forward surgical team hospital. And then you've got some overseas definitive care. Those used to be known as MASHs, or Mobile Army Surgical Hospitals. They're called CASHs now because they kind of split up the MASH into that level 3 or forward surgical team, which is called a FAST team, and the CASH, which is the combat surgical hospital. And then the last care is the level 5, or it's care in the U.S. or care in a European hospital, sort of like Landstuhl in Germany. The Special Forces medical teams, which I'm a part of now, it's actually not listed on this slide. They're about a level 2.5. They're not quite a theater level hospital care, but we have a little more resources than that forward resuscitative care team. Next slide. So as you can see here, getting loaded or unloaded, I'm not exactly sure of this of what's going on in this picture. Loading into that Chinook helicopter on that little dune buggy. That little dune buggy is the hospital. So that's everything that we carry with us to take care of our patients on any particular mission. So we kind of load that up for each individual mission. And they're backing it onto the hospital or driving it off they're backing it on the helicopter or driving it off the helicopter, because when we land, that's how we get out. So one person just drives that thing off, and we may be a little bit in the air still. Everybody else has to jump out, but it is kind of an exciting little trip to go on. Sometimes we'll go in a double-bladed Chinook helicopter like this. Sometimes we'll actually fly in a little airplane. But they drop us off, and we drive out and set up where we're going to operate, and that may be in a building, in a tent, in a field, wherever. Next slide, please. This is another nice picture of Afghanistan, where we're probably in the back helicopter, and the team that's running the mission is in the front helicopter, and we fly off together with them, because the rules of engagement for medical, what's called the MRO, or the medical rules of engagement, currently in Iraq and Afghanistan, is that special forces soldiers, cannot be any farther from a 60-minute extraction point to their medical treatment facility. So that's why we travel with them. If you may have remember back several years ago, there was that incident in Africa where the special forces were ambushed, and it took them about 6.5 hours or so to get to any kind of definitive medical care, just because the medical rules of engagement were a bit different in what's called AFRICOM, or the African theater, versus CENTCOM, or the Middle Eastern theater. Next slide, please. Another, interesting picture of Afghanistan, one of the other bases I've got to live on, in various times of my life. If you think it looks kind of crappy, it is kind of crappy, but it's a fun kind of crappy, where there's a lot of camaraderie. We're out to sort of protect each other. Being a doctor there, where it's not, I wouldn't say it's safe, but it's not unsafe. Because the Joes, the operators that are there to do their job, they know that we're there to do our job, and they do a lot to make sure we're protected, because if they get hurt, then their protection gets hurt. Next slide, please. So that's another sort of, I always call this a cool guy picture of myself and one of our other surgeons, kind of just hanging out, waiting for things to happen. And again, a lot different than kind of the normal Army. Just in the way that how we get to go about things. Next slide, please. So this story kind of takes place where the dot is up in what's called Kunduz province in Afghanistan. That's in northeastern Afghanistan. Every year there's a big battle in Kunduz where the Taliban and the U.S. or coalition and Afghan forces, fight it out. But this happened, another one of those big battles. So the background, this is the Afghan commando. There's lots of acronyms in military medicine and military in general. So he was TACEVAC, or tactical evacuation from the battlefield right to our little hospital. There are multiple casualties with this. He was hurt in a dismounted blast injury. He shows up with a bilateral lower extremity amputations, and his blood pressure, if you can remember the last, he's a young, relatively healthy guy. So if you remember the last case with the car crash, they had heart rate in the 140s, but their blood pressure was in the, 110s. This guy shows up with a heart rate in the 140s with the blood pressure in the 50s. So we're already starting kind of far behind. And I always love these pictures of working in the military theater. Hard to tell who people are. I'm kind of the guy kind of bent over, the short guy on the far right, who's doing some operating. Interesting enough, there's a guy in a brown T-shirt there. He's one of the Special Forces medics, and you can't see underneath all our gowns, but he's got his sidearm on all through the initiation of the resuscitation and surgery as well. Next slide, please. So his injuries included the following: he had bilateral amputations and perineal floor muscular injury, vein and artery injuries. He had a pelvic fracture, when we're staging injuries in trauma, we look to the injury severity score, and that's taking an assessment of the highest injured several body systems and putting them together. So that score can range anywhere from 1 with very little injuries to up to 75. 75 is the highest score you can get. Any ISS score over 15 is considered a major trauma. This patient's ISS score was calculated out to be 66, which is kind of close to dying. Next slide, please. So our initial evaluation of this patient, he was diaphoretic, he was pale. We all know how to interpret these numbers here. You can see his ABG. ABG is 6.9 with a base deficit of -24. That's starting off really behind everything. So as soon as he was intubated, he lost his pulse. And one thing that this is kind of a patient who is in dire straits from the very beginning. We all know this, and in different parts of the world at different times, patients would be taken care of differently. But working with the special forces, the Green Berets, they're a little bit different than, say, the Navy SEALs or the Marine, Recon Rangers or anything. Their whole goal is to work with the indigenous people to sort of teach them to fight themselves. And they teach us from the very beginning that one of the most important things is for these people is to know that if they get hurt, somebody's going to take care of them. So even if people come in, at death's door, we have to do our best job that we can to take care of them, even if we don't think they're going to have a great successful outcome. Because if they see us just giving up early, they're not going to want to fight for you. So part of this is not so much show, because we really are doing our best ability to take care of them, but it's doing nation building at the same time as taking care of their friends, so that they know that we've got their backs. So he was intubated, he lost his pulse, and immediately, I performed, you can see kind of in this picture, if you kind of know what you're looking at, that we went into the chest immediately to cross clamp the aorta, and sort of he could regain his pulse, because we sort of stopped the blood after the heart, full resuscitation, got good venous access, and started our base-wide massive transfusion protocol. If you think of your own hospital's massive transfusion protocol or blood response, you may be able to have to stop at 50, 60 units. Sometimes I've had 100-unit blood transfusions in massive transfusion protocols in the States. When we're flying into some place like this, you are only carrying 20 or 30 units of blood and plasma and 0 platelets. So they have initiated on all these bases what's called a walking blood bank. So we all know everyone's blood type, and people start giving their blood sort of, if their job's not essential, they're a blood donor immediately. Next slide, please. So with this guy, we were able to sort of control things. So you got, looks like with 16 units of blood and 14 units of FFP, he probably got just about every one of the blood units that we had with us. We also got the requisite antibiotics, tetanus, calcium, some bicarb, and some TXA to try to make something clot off. His surgeries included the BKA and above the knee amputation on the left. We repaired the arteries and veins. You got a laparotomy and the repair of the iliac vein as well. And then the chest tube with the closure of thoracotomy. By the time we were done resuscitating him, we had resuscitated him to that ABG, 7.3 with a -5 base deficit. And we have to, once we're done with the patient like this, we have to turn the operating room into an ICU and work on them until, the fight's over, so that they can actually get these people out of here. So they had to be able to land another helicopter to get him off to the higher level of care, and that was over at Bagram Airfield, the Combat Support Hospital. Another picture of what he looked like kind of before we were packing him up. So this is all damage control surgery. You can see there's tourniquets on both legs, and that's what's going to be sent with him on the helicopter, because for whatever reason, I'm sure that all of you have had to deal with an amputation that gets done at 3 o'clock in the afternoon, and 9 o'clock at night, something's bleeding like crazy from there. In anticipation of something bleeding like crazy when you're in a helicopter, we leave these tourniquets in place so that the medics on the helicopter can just tighten down the tourniquets if they need to. And you can see that if you're an orthopedic nurse at all, you might be a little taken aback by my attempted external fixation of his pelvis, but that's a femur external fixator or a long bone external fixator. We didn't have a pelvic fixator with us on this mission, so I just had to kind of improvise to do what I had, and I used a long bone fixator to bring his pelvis back together. Next slide, please. And then each of these people here in this picture, as we're cleaning up the operating rooms, because there was the patient that we had and other patients as well. These are all doctors and anesthesia providers. So once we set up our operating room on our own, do our operations, take care of our patients, at the end of the day, we got to clean everything up because there's no EBS staff to sort of come up behind us. So this is the doctor sort of cleaning everything up. And then, so the ongoing care of this patient. So that's my ongoing care after that night of surgery kind of just collapsed. We've sort of followed up with him when we were leaving Afghanistan. And he was still, at that point, he was still alive. He'd had multiple washout surgeries. He had a tracheostomy. His left hip, which we left him with an above the knee amputation, eventually needed a hip disarticulation. I think this person was operated on early in one of my tours, and 4 months later, he was still sort of fighting away at the combat support hospital in Afghanistan. That's my presentation. I really appreciate you guys, allowing me a chance to speak with you, let you know what options we have for or options and plans we have for ongoing trauma system care here in Richmond, and letting people, a lot of people that know us from our hospital system know what we have, but trying to introduce us to a new group of professionals, the nurses in the critical care field. It's always good to be able to do that. So if you guys have any questions, I'm happy to answer them. If not, it looks like I ran over time a little bit. So I hope I didn't interrupt too much of your night.
Does anybody have any questions for Dr. Layman? Dr. Layman, we really appreciate your time. It was an excellent presentation.
Awesome. And I see some stuff in the chat, so I'm always happy to see people typing good notes to me and about me. All right. Well, you guys have a good evening, and thanks for letting me take part in your meeting tonight.
Okay, for those of you that are on, I'm going to pull up the QR code so that you can get your complete the evaluation to get your CERP. It will be emailed for you. Just know that you need to do the evaluation within the next 2 weeks in order to get credit. And hold on one second. I just had it and I lost it. And then we also have a couple of door prizes that we would like